More recently, there was a trial called the RESONATE-2 trial, which read out, which was a frontline therapy for patients over 65 receiving their first treatment with either chlorambucil or with ibrutinib. And that trial was positive and showed improvement in progression-free survival, as well as overall survival for patients who received ibrutinib first as their first therapy. So the question here is, how do we manage patients in the first-line setting? Does the RESONATE-2 trial support giving everybody frontline therapy? The FDA gave approval for ibrutinib in the frontline setting, not limited to people over 65, which were the patients who were treated on this trial, but broadly. And so there are some areas of debate and areas where there's not clear data that supports what people might be doing in their practice. I think for me, really, the only absolute in the frontline setting is that patients who have a 17p deletion, which is a very small percentage of them, it's about 5 to 8% of patients in the frontline setting. Patients who have a 17p absolutely should go on ibrutinib therapy. They should not get chemoimmunotherapy or chemotherapy because their disease doesn't respond to that, and we're probably only doing them harm by giving them first-line chemoimmunotherapy.